My name is Dr. Rob Streisfeld, Doc Rob. I'm excited to be here and moderating this panel of very informative experts here. This is probably the biggest challenge that we have is not enough time. And that's a good thing. We have a lot of content to go over, so we're going to try to keep, I'm going to try to keep the bios and intros really short, because if you want to learn more about these docs and our speakers, there's bios on the website. You can ask them more questions afterwards. But let's get into the really important facts. So what we're going to start first, I think that before we dive into all the caveats of dosing and all this mastery, I'm going to ask Dr. Rosado to jump down real quick and hit that board and just give a basic 101 on labels and dosing, and then we're going to jump into the rest of the panel and go over some of your questions too, because I think it's really important to be a little bit interactive here if we have time to answer some of your questions in the audience.
Everyone see okay? I also have a big mouth, so I'm from the Bronx, so. Okay, so the biggest challenge, especially not only in the United States, but all over the world, when we talk about milligrams per milliliter, people don't understand what that means or what that is. And in the cannabis world, it's rare that you see X amount of milligrams per milliliter. All you see on a bottle is what? What do you see on a bottle? Total milligrams. So to avoid that, we're going to discuss how to calculate that out, which I'm sure many of you know how to do. So this is a Cannabis 101. No, that's not the middle finger to you guys. So it reads 3,000 milligrams. So, and there are 30 milliliters per bottle, usually. So how many milligrams per milliliter on that one? 100 milligrams per milliliter. Everyone know how that came out? Cancel out to 0. 3 into 300, 100. So that's how many milligrams are in a milliliter. So when you're coaching people, when you're explaining to people, depending on what you want to give them, then you know based on the gradient. Now, a lot of droppers don't have markers, and so that's the challenge. So when you're promoting a product, make sure that there are at least markings on the dropper, so that way it makes it easier for the people that are using it. Any questions on this? All right. Dr. Rob?
Thank you. Again, this is some basics. I mean, even the 30 milliliters confuses people that equals 1 ounce. Like, there's so many numbers and back and forth that this is, remember your high school math that you wanted to run out of, and this is coming back to haunt us all. But it's really important because I've seen a lot of dosing mistakes, whether it be CBD or THC. Even on the medical professional side, they're still trying to figure out the proper dosing. We have great medical professionals here that do frontline work, so we're actually seeing the effect of these products with patients directly and how it's working and effective. So with that, I know, Dr. Adam, you've been doing some one-on-ones, but your background, what are some of the key, you gave us a whole bunch of great questions today, so I'm going to let you start off with, one of the things that I started with when I was doing this several years ago was manufacturers were saying you need a lot because you want to move a lot of product. But in reality, we start getting a lot of effectiveness at lower doses. So how do you, when you for the first time, let's say you're brand new to CBD or anything cannabis, and you walk in, you had a patient walk in, how do you explain to them how to start their dosing, or how this product might be dosed based on the individual in front of you? I know it's a lot of different variants. But.
Yeah. Well, I think the first thing you mentioned was it's a new patient. So first of all is, question always becomes, as I always ask all my patients, are you a cannabis user or are you not cannabis user? Because that's going to drastically change the way I approach that patient from an education standpoint as well as from a dosing standpoint. If it's somebody who's completely naive to cannabis, I think before we even start talking about dosing, the first thing that I like to elucidate is, one is, what are we trying to treat? What ailment are we trying to treat? Second of all, what's going to be the best route of administration? Because routes of administration are what ultimately are one of the biggest factors of what impacts dosing, as well as how people are going to respond, especially when they're trialing and starting out, for the first time. So, when it comes to a patient that comes in, we determine, their age, any comorbidities, any sort of potential interactions, which we'd have to be, worried about. Once I get to the point where I come up with a route of administration, then I typically, now again, we're talking about CBD here. We're not, talking about, THC right now. I typically start them out on a pretty standardized regimen depending upon which route of administration we decide. I'm a pretty big fan of starting out naive patients, particularly if we're trying to treat a particular ailment with THC, to be more on the vaporized form, as opposed to with CBD. I tend to go more towards the edibles, oral submucosals, things of that nature. And the reason is for that is because dosing is so challenging. And the one thing that we know, so for example, when you're talking about vaporizing, whether it be CBD or THC, we know that with a typical inhalation on average, an individual is going to receive somewhere between 1 to 10 milligrams of cannabinoids, depending upon length of inhalation, depth of inhalation. And the nice thing about vaping is that I like to consider it's like sipping on alcohol. Okay, meaning it's a lot easier to titrate. We all, if you have an alcoholic beverage, what do? You have a sip, you wait a couple minutes, you have a sip, you have a couple minutes, until the point where you say, all right, I've had enough sips, I feel good enough, I don't need to have any more, or else I'm going to become intoxicated. That's the first, one of the ways that I approach patients who are naive. They're looking for THC. Now with CBD, it's different, because a lot of, CBD doesn't work necessarily immediately, and that's something that people need to understand depending upon what you're treating. So with my patients, if we're going down the CBD route, I've got a pretty standard dosing regimen that I recommend for patients who are starting out. With the oral medications, as well as with the sublingual medications, the first thing we try to figure out is, are they dealing with a full spectrum product / broad spectrum product versus an isolate? We know we have pretty good evidence that isolates typically tend to have a more narrow therapeutic window, and they also tend to require higher doses. So for individuals who are starting out on an oral agent, if it is a broad spectrum or full spectrum, I'll typically recommend 1 to 2 milligrams per kilogram. So for the average person, let's say they weigh 150 pounds, that's going to equate to somewhere around 25 to 30 milligrams of CBD. Whereas if they're looking at an isolate, I tend to be a little bit higher with that, somewhere around 2 to 5 milligrams per kilogram. I'll stop because I feel like I talk about this more.
It's great. These are great lead-ins. In part, some of the research has been showing that up to 200 plus milligrams of isolate is needed in order to have an effective dose compared to 10 to 15 milligrams of full spectrum oil. And so when you're looking at your dosing, it's also inherent that you have to understand what form, what else is in this product. That isolate, while it may be easy to dose because it's an isolated compound, may not be as effective, and you might have to take a lot more of it, and then there's a cost factor. So there's a lot of these components. One thing that you mentioned about vape, and some people's eyes lit up because vape is such a hot topic right now in general. It's a fast-acting, quick absorption method, and I know that a lot of people are hearing all the vape issues right now, and I know we're talking about dosing right now. From what I've been researching, and recently just came out with a new, they call it PSA alert, which is it's not even the vitamin E. It could be the substrate. This is something that's come out recently. What the plants are grown in. A lot of these cocoa peats and cocoa cures are beds for bacteria and fungus. And those products are now being, those bacteria and fungus and molds are now being brought into the plant. And then because the manufacturer's taking this lower grade product to make into oils and extracts, those oils and extracts going to your vape pen could be loaded with chemicals and toxins from the molds and the funguses. So we have a lot of work to do, but it's always ask for COAs and go backwards. Now, depending on, you said, we have doctors here, so a lot of what people are walking in have medical issues, medical complaints. But we have a lot of people that are buying CBD products right now as a supplement of sorts, as a multivitamin or vitamin D or probiotics, another one of these categories of better living or health supporting. Dr. Melly, I don't know, do you see anything as far as the different age groups and also different interests from a more of an average consumer to a patient? Do you have any guidance on, giving some information on those typical customers?
Great question. So I am a gynecologist by training, but I also am a cannabis physician, and I see men, women, children, and I currently run a study on the over 65 population. And I will tell you that's a really interesting group of people, because people over the age of 50 are the highest new consumers in the marketplace. And once you get above 65 and above 80, and believe me, there are a lot of people out here who are living good lives over 80. I think in my last panel, there was a whole definition, old people over 60. I don't think those of us over 60 think of ourselves as old. But yeah, I'm in that group, okay. But what I would tell you is that they're on many different medications at the same time, and you need to understand which of their medications may or may not be impacted by CBD. Now, everybody in the panels today has said the same thing, and I would agree. It would be very rare to see a drug-drug interaction with what we use, because we don't use large enough dosages of CBD, but maybe over time we'll run into that. I've been doing this for 4 years, and I have had one patient in 4 years who was using a blood thinner, and we had to watch out for the dose because the blood work came back abnormal after implementing cannabinoid therapy. So what I will do with the older population, because they're afraid, and I think that's it, more people are afraid than not. So the adage, start low, go slow, don't be afraid to say no. There's only one issue with doing that, and that is if they don't feel or see any difference, they're going to stop using before they get the benefit. So I'm not going to start bargain basement low, but I'm mindful, and I might say to the patient, well, first, we're going to start with a CBD product, and then we may go to a full spectrum, and then from there with something with real THC in it. So I sort of have a step-up program in my over 80 population. We will start with an isolate, then we'll go to a full spectrum, then we'll go to cannabis. But what I tell them is, if you come back to me after 2 weeks of trying it, and I see these patients back very frequently, it's one of the joys I have in what I do. I don't have to charge them, and they love to come back. And the interaction with the cannabinoid doctor is very important. I would rather have them come back, and I tell them this, I'd rather have you come back in a week or two and tell me you're not sure it did anything, but nothing bad happened. You didn't get extra tired, you didn't have an upset stomach, you were okay. And then we can get more aggressive with going up and titrating. So for me, that on-ramp to the expressway is very important to get them confident, take away fear, minimize side effects. And then once they feel good about that, then we can, more quickly ramp up and get desired effect.
That's great. And so one of the things that Adam mentioned earlier was delivery systems and routes of absorption. I remember when I was talking to doctors 5 years ago, one of the chief reasons they came in was pain. All right, so let's look at some of the more common things. So for pain, I often recommended an ingestible, and I also recommended a topical. So sometimes these combined therapies or combined approaches work really well based on what's happening. Someone that has long-term anxiety, you may want to give them a capsule or ingestible, but they may benefit from a vape that might be, or a tincture that may be a little more fast-acting for more acute cases, but while we're looking to support the overall response through the digestive tract, and that's where I want to say, like, when you're talking about THC and CBD in different routes, there are different receptors. So I don't know if you can address some of those effects of where the receptors are more heavily found that may trigger effects of different compounds.
Absolutely. So hi, everyone. My name is Cohen Kakar. I'm a pharmacist. So, you bring up a great topic, and it's something that's come up in a couple of our panels, is the dosage form, and then, like Dr. Bone mentioned, the patient compliance aspect. So in pain specifically, there's a lot of sources of pain, and to this day, even in medicine, we don't have an objective way to measure pain. We give them a scale, they tell us 1 to 10, and we have to take their word for it. So it's really dependent on the type of pain you're looking to treat. I would say systemically is where people start, you're right. And then you have to be creative with the topical as well. There's a lot of good formulations, like Dr. Abadili said. CBD might not work immediately. So when you do a topical, there's formulations that include other pain distractors like menthol or camphor, so they can provide that immediate relief. You see cooling cream, that's also another distractor. So I think the combination therapy is the right approach because that systemic will start building up their cannabinoid system and potentially treat the pain and inflammation and the other causes that's leading to that pain.
That's awesome. And so, like I said, there's so many different people coming in with different conditions. And again, as doctors front line, we see younger people. We talked about some older, the elderly people. But I know that a lot of people are looking at younger. The CBD movement, in part, was brought public by children. Children with seizures and other issues, even autism, that's found benefit from CBD. And so, can you maybe talk a little bit about the younger population? And again, there are some concerns. But one of the things that before I jump in, let you do that is, even though this is CBD Expo, I don't know if anyone on the panel would say this is all about CBD and we want to throw THC out, right? So I want to make that a point that a lot of the industry pushes CBD isolate, CBD, don't worry about the psychoactive effects. Every time I do a talk on stage, I address the term psychoactive because medical professionals who look it up, it does not mean negative. Mm-hmm. It just defines an effect, right? So we want effects.
Coffee psychoactive.
It's totally psychoactive, exactly. Positive psychoactive. So when that language gets thrown out there a lot in the industry, oh, it's psychoactive, that's bad. That's not. Chocolate, coffee, psychoactive. So I just want to bring that a point that THC, we're not throwing THC out, and that's where some of the full spectrum benefits of even having a small amount of THC seem to benefit. But in some populations, THC too early could be a problem. I don't know if you could address some of the younger patients and things of that nature.
Yeah. In fact, right before we started, she wants to. We're going to collaborate on some children that she manages. Which is interesting because when I was in training, the specialty that I liked the least, and I was the chief resident, and when we had to rotate, I rotated through pediatrics in the month of February. Why? Because it's the shortest month of the year. Because I did not like pediatrics at all. However, the universe had a different plan for me, and I was the first in the state of Florida to recommend a 1-to-1 CBD THC combination to a 15-year-old that had a severe stage 4 rhabdomyosarcoma, which was an aggressive tumor of the head and neck. In fact, November 8th was our 3-year anniversary when I recommended that for him. So as far as pediatrics goes, as a result of that, people were driving from Miami all the way up to Orlando, where my practice was, for me to manage their pediatric cases. And with children, especially children that have epileptic seizures and are on 3 to 5 anti-epileptic drugs, I am very cautious about when to use the medication for the fear of the drug-drug interaction because the therapeutic index for anti-epileptic drugs is very, very narrow. And any change or alteration in dosing can cause them to become toxic or can deactivate some of the medications. So when I start weaning them off of medications, I pick one medication at a time, and we monitor blood work because they have to have blood work done every month anyway to check their liver enzymes. So I verify not only liver enzymes, but I also verify Keppra levels, Depakote levels, phenobarbital levels, and make sure that everything is in therapeutic index, and if anything's off, then we know how to back things off. So when I do recommend an oil for children, because most of them don't know how to inhale, unless there's a product that, like in our area, one of our dispensaries has a nasal spray, and so I recommend nasal spray for some of the children. But I always encourage the parents to give the medication either an hour to an hour and a half before or after their conventional medications. That way, to avoid the possibility of any interaction because they're all metabolized by the cytochrome P450. And so as a result of that, I'm very cautious. As far as inhaling, I do agree that is the fastest, but as I stated, children don't usually know how to do that. So, not that I ever inhaled, and I may not have a lot of experience in this, but I talk about shotgunning to the parents, where if they have a card, I tell them to go ahead and get smokable and go ahead and blow out into the child, and that way the child will breathe in the medication. So that's an excellent way to bypass the liver immediately. Eventually, it'll be absorbed into the system and makes its way into the fat cells, and then it's released later. So there will be some metabolizing going on in the liver, but not at the same concentration as if they take a pill or an oil.
That's great. And, one of the other things I wanted to discuss, or at least bring up, was the THC CBD balancing game. Where for most people, the way I explain it is THC is your gas pedal and CBD is more like the brake. And in this world, our society is all about the gas pedal. Constantly go, stress. And so for a lot of people, whether they have a medical condition or not, finding a little bit of that brake pedal, a little CBD, provides a tremendous amount of benefit. One of the other factors that we talk about is if I had a client taking CBD for a while, then got her medical card, went to the doctor, and he did not have the 10 milligram or 25 milligram THC capsules in stock, and gave her a 50 milligram capsule instead. Now this woman was sitting, throwing up, spinning for 7 hours because it was not. Now, if you've preloaded CBD, take CBD before THC, right? This tends to make THC more impactful, increase the effectiveness. For those that have taken a THC product or maybe ate too much of an edible, like that athlete on a plane recently that was having a panic attack for taking too much THC in their edible, had they take CBD, they could actually kind of antidote some of that THC effect. And I love that you brought that up with the medications. So for so many people that are taking CBD 10 milligrams, 20 milligrams daily, like a supplement for better health, great. But those that are on other medications, I know this one, my own mother was put on, had seizures, had 5 anti-epileptic drugs at the same time. And they did not know what was working and why. It was just, it stopped the seizure. So I always talk to your medical professionals whenever you have a medical condition that requires this cannabis therapeutic interaction with other medications. I think that's really key part. Now with liver health, this is a key thing that keeps popping up. Liver health. For many years, CBD was like, oh, it's safe, it doesn't affect any medications, but it does affect the liver. It does affect the way the liver metabolizes. Just like you see some medications don't do with grapefruit, right? We have some of these concerns, just like blood thinning, fish oils, these are things that, so if you have questions or these concerns, this is where you have such great doctors that are working frontline. What are some of the other challenges, Dr. Adam, that you've seen maybe confusing parts? Like again, we're talking about the mystery of dosing. Do you have any other common issues that we seem to pop up a bunch?
We can certainly talk about the whole, liver and safety issue, and I can just make a few general comments on that.
Please.
First of all, just by show of hands, how many people have been in the previous 2 panels? Because this has been discussed a couple times. I don't want to repeat myself over and over again. But to make a long story short, there's been some studies that came out, or one study particularly, which talked about liver profiles and liver toxicity and stuff, and that study is completely flawed in majority for so many reasons. And I get asked the question all the time: what do you do with patients on medications? Okay, patients who are on medications, the first thing you have to ask yourself is how important are these medications that they're on, and what happens if you alter those medications? So for blood thinners, which we know CBD has a potential to alter some of that. We've never seen it in our practice, but we do tend to follow it with the higher doses. Clearly, if you have a blood thinner, which is, the concentration either gets too high, well, they run the risk of bleeding, or if it's too low, they run the risk of clotting and having problems from their blood clots. Same thing with seizure medications. If their seizure medications are not monitored and they go too high, well, they get toxicity. If they're too low, they run the risk of seizures. The studies that have shown that CBD is potentially harmful to the liver the studies have shown that these are doses that we're not even coming close to prescribing. I mean, they're astronomically high doses. You look at the studies from Epidiolex and from Sativex and stuff, yes, there's been slight elevation in liver function tests, but these were in patients with moderate to severe liver disease. At the same time, you gotta, as a doctor, I don't know why we're making such a big deal out of this, and I'll tell you why. Patients come into our office, they've got a medication list that's 18 medications long, okay? Now that doctor who prescribed these 18 medications, are they sitting there going through every single one, measuring every single liver test, measuring every single, how this drug is gonna be metabolized? And the answer is no, they're not. Maybe particular indications, maybe particular medications, but to tell somebody that they're taking 25 milligrams of CBD a day, and that as a result, we need to measure your blood levels of all this and all that, I think is overkill. It's my personal experience, and we haven't seen anybody have any negative outcomes from taking doses that low. Now, when people are on blood thinners, I still tell them, listen, we need to be mindful of this, we need to be cognizant of it, and we need to, at least for the first few months, keep an eye on what your blood levels are. The problem is that a lot of the blood thinners nowadays, we don't have ways to measure them. Coumadin, warfarin, we can measure. Other blood thinners, we can't. But again, I would ask the question with some of my physician colleagues here. Patients are coming in, they're on 18 medications at their medical doc. Do you think that medical doc sat there for hours and hours and hours, went over every single medication, every potential interaction, and every way that this medications are going to affect each other? Because they're all processed by the liver. So how is 25 milligrams of CBD going to affect it? And the answer is it's not.
That's great. Yeah, again, there's so many nuances here, and I know I want to open this up to Q&A, but there's one other aspect which I probably don't even have time to dive into the depth of, but being that I came from about 20 years of nutraceuticals, natural products, dietary supplements, a lot of the products, and they're even here, and I'm not saying good or bad, I'm just putting it out there, there's water soluble, there's nano, and there's all these different kind of differentiators that are trying to increase bioavailability, but how many of them are actually doing the testing or showing increased bioavailability or absorption? These cannabinoid molecules are fat-loving, right, typically. So if you start taking all the fat and the water solubility and take the fat away, this could be effective if someone is on a fat-free diet, which is not as popular nowadays as it was years ago, but if someone has low body fat, that could even affect absorption rates and how it affects the receptor sites. So does anyone have any thoughts on the nano or water soluble aspects of dosing? Because it's a slippery slope. I'm not sure you want to dive into it in depth, but anyone? I know.
We'll let the pharmacist.
I'll take a stab at this. And forgive me if anyone disagrees.
Yeah, that's what we're here.
So it's my opinion, we hear about all these ingestible products. And when I say ingestible, I'm not talking about the oils that are taken sublingually, but capsules and edibles. And this is, again, on CBD alone. And it goes through what everyone has probably heard of, first pass metabolism. And I'd say most of the CBD products are not water soluble. And therefore, after that metabolism, a very low percentage of it is actually absorbed. When we talk about the nano and the new water-soluble CBD options that we are hearing about, theoretically, yes, there should be better absorption, absolutely, by the science. However, to actually measure that, you have to do an invasive study to take blood levels. And until Big Pharma or another big entity comes and makes that investment, I don't think we can make a clear and resounding claim on that. Again, the science says there should be better absorption, but I haven't at least seen any strong data supporting that just yet.
Thank you. Like I said, that's not saying it doesn't work, but it's still buyer beware. That's the thing we got to always ask. Go back and ask for your COAs. Talk about your, these tests that show the bioavailability. That show me this. Be what I call conscious consumers.
Yeah.
Just ask the questions and try to learn more. And that's really a big facet of why you come here. And I appreciate everyone showing up today and these great events, and Mace does a great job bringing wonderful panelists on. So instead of us just throwing out random topics, I'd love to, start to open this up. If you guys have any specific questions, I know that among us on the stage could hopefully answer them, or at least have something to come back to. So does anyone have any questions at this point? I knew there's going to be none. All right, so the question basically is, you go on the shelves, you go in the doctor's office, you go online, and you see milligram concentrations from 250 up to 5,000 in the same bottle. As physicians, as people who recommend products, how do we determine the starting point? I think we talked a little bit about that. Now, when it comes, I think, to the medical side, someone comes in with a medical condition, still more research needs to be done, but there's a little bit more guidance. But I think there's a nuance. I don't know if anyone wants to jump in and try to address. I know we talked a little bit about that.
I'll mention something which has to do with money. Okay, that's a big reason. So I keep 375s and 500 milligrams in my office because there are people who are so hesitant to try. They don't want to spend $60, $80, $100, $150 on a bottle. So we will start with something small, have them come back. And then they can decide if they want to get a bigger bottle, because once they get to a bigger bottle, they'll have to go down in their volume. So yesterday I spent some time with the CEO of a very well-known CBD company, and their theory is, well, start with a bigger bottle and just tell the patient to use 1 drop or 2 drops, okay? There's some issues with that. Can you control the dropper well enough to not accidentally get 3 drops, right? Some people's hand isn't steady enough, and then they'll spill some on their tongue and their lip, and then they're not sure if they really got enough. So we usually start with small droppers and small amounts so that they're more confident in what they're getting. Like you could just say, take the whole dropper full, and they won't be getting so much, as opposed to look in a mirror and make sure you only get 1 drop, because that's very hard to do.
But instead, why don't you talk as a consumer, that other than money, who's going to benefit from a 2000?
Oh, you don't.
And
You don't.
that's why I said in the very beginning is it's very often, and I hate to say this because I come from the industry, that's usually the manufacturers pushing product. What I've always said is, look, I've been doing CBD, hemp extract for 6 years or more, full cannabis for that, and at one point when I was doing shows like this, it was 18 cents a milligram for CBD. Now we're talking about 3 cents or less. So the question becomes, at what point, I've called out some of the largest brands in the country on stage publicly, not in a bad way, but a question saying, I understand the early 4 years ago, the burden of cost to get these products on the market was expensive, but at what point does your retail price point start to come down? And there are some brands, and their mission is specifically to drive the price down of CBD for consumers to have greater access to higher potent products. There are brands out there that people over profit. That's what their focus is. They want it to be at Costco and Walmart at quality product at cheap, affordable price for everyone. I do this even in the pet market. I have a breeder that has 150-pound dogs, right? So it's, again, human size, and they want pet treats. But the average bag of pet treats are for 20-pound dogs. So for them to take and treat their 150-pound dog at 35 milligrams twice a day becomes cost prohibitive to treat the dog with this product. And so this is going to change over time. As much as we've been CBD everywhere, and I think Google just announced that CBD search engine hits were highest ever in 2019, and it's growing, and you guys are coming out learning more, that price is going down, and this is going to change the marketplace over the next couple of years significantly, because we've seen it go down already significantly. And so that's a big question, but a lot of times it's who's selling it, and how many people are in between from the supply to the customer, So it comes down to margins and profit. So, good question, though. Yes?
Is there any issues with THC and the opioids that are flooding the market in terms of contraindication?
Does anyone have experience with opioids?
Oh, yeah.
I had it. I just wanted to correct it. I could answer it all.
Not personally, but
Hey, it's okay.
I've partnered with a pain management clinic, and the goal is to wean the patients off the opiates because we have patients that are coming in that are taking, in excess of 90 milligrams of morphine equivalent per day. And so we're weaning them off. When they use THC, by using THC, it lowers the threshold or the tolerance by 3.6 times of the opiate dose, so they need less opiates when they use the cannabis. So on the first month, when I introduce the cannabis and I do THC with CBD, I leave everything the same on the first month. Now, if they are doing long-acting opiates like an extended release oxycodone and then a short-acting oxycodone for breakthrough pain, I encourage them to use the vape pen or the inhalation to replace the the oxycodone, acetaminophen, short-acting. So that way they use that for breakthrough, because typically inhalation lasts anywhere between 2 and 4 hours. So I have them inhale every 2 to 4 hours to control and maintain them medicated. Then when they come in on their second month, that's when I begin to cut let's say they're on 20 milligrams, I give them 15 twice a day, then 10 twice a day, and little by little. The first paper I published this year was on a patient that was taking 42 to 58 pills per day. She started with 20 milligrams of extended release twice a day and 10 milligrams short-acting 4 times a day. And within 3 months, she was off of all the opiates. She was off her benzos. She no longer needed the medication for her opiate-induced constipation because she was no longer on opiates. And she was on a diuretic because she had swelling, well, she had generalized edema because she was retaining fluid, so she was no longer taking Lasix. She no longer had to take her Zofran because she was no longer having the nausea related to the opiates. So that's how we began to cut a lot of the medications down. So that's the protocol that I utilize in patients with opiates.
And been showing very effective. You know, that's the big thing. This is not just a one-off anecdotal. This is showing more and more that this is a pathway to help us get through this opioid crisis. And you know, even some of the opioids, you know, these compounds, you know, from plants, like, you know, even like I said, people used to chew coca leaves and they didn't take them into machinery and extract them and multiply them. And I always use the example is that the endocannabinoid system, which I'm sure through panels and conversations you've all learned about and talk about, is in all these mammals and down into seahorses. And then I always use a reference of like a 200-pound deer walking through the woods and nibbling on some buds and some leaves of some cannabis plants and getting endocannabinoid system support. Did it need to be extracted and heated and isolated and multiplied in concentration thousands and thousands of times for that animal to get benefits from nature's gifts? No. So again, when it comes to dosing or when it comes to these products, very time a low dose can stimulate endocannabinoid system that has been kind of left void of any nutrients. And I think that's something that we have to look at is how does our body wake up when we start to stimulate the endocannabinoid system? I'm sure not just opioids, but SSRIs, anxiolytics. Science has been showing that by taking them chronically, you're actually down-regulating your own body's production of beneficial endocannabinoids. So you take an antidepressant because you're depressed, but that antidepressant is making you more depressed because it's shutting down the natural anandamide bliss molecules to make you feel better. So to focusing on pathways off the pharmaceuticals, and I'm not knocking pharmaceuticals in certain areas, like I said, are beneficial. As a naturopathic doctor, I'm, again, further on the plant side than most, but I am not against good pharmaceutical therapeutics. It makes sense to utilize in appropriate places. So again, thank you for that insight on that too. I don't know if anyone has any more to share on that opioid issue, or we just go to more questions.
Well, I would just say, touching on this, is that I usually tell the patients, and I learned it. Did I learn it from you last year? Were you the one who said this? It was subtraction by addition. Some panelist last year said, if you're trying to get off opioids, because the patients will say, well, doctor, how do I wean? And I say, okay, it's subtraction by addition. So we add the cannabis first, and then you subtract the opioids. And unlike my colleague here, I sometimes tell the patient, I just want you to come back in a couple of weeks or a month, and I want to see what you're doing. Most of them have already reduced on their own by at least a third at their first visit, and within 6 months, easily 50%. The last 50%, I'll be honest, it's how motivated is the patient to keep going to get off. Do they want to spend enough money to buy enough marijuana to kind of help them get the rest of the way off, or do they want to do this combination? But they still all reduce. I haven't had anybody not reduce.
I love that. I love that subtraction by addition. I do that with diet and food. I'm a chef as well, and I always said it's not about dieting and starving yourself away from food. It's actually giving yourself all the nutrients from good quality food to support the body's own health, and then you'll realize that all the other things start to fade away on its own. And the same thing here is that you can actually support the body, and then the other negatives start to fall off on their own. It's pretty interesting.
And our practice, we make it a point too to be very clear with our patients when they come in that the point of coming for medical cannabis is not to simply add another medication to your medication list. The job of it is to decrease polypharmacy, starting with the opiates, and then from there we wean down from there. And we're very honest with them. In 3 to 6 months, if we're not seeing an improvement, they're coming off the program, and we're not going to prescribe them THC anymore, because the job is not for them to keep taking their Percocets and getting high on THC at the same time.
That's right. And first, now,
Are you aware of any conditions or ailments that CBD has an adverse effect on people? I read a study, I think it came out late last year, there was an adverse effect for patients that had glaucoma that were taking CBD.
I haven't experienced
I mean,
that.
I've seen, we've done some research in the genetic side of things. So like they say, oh, CBD is great for kids with seizures. Well, 8 or 9 out of 10, yes. 1 or 2 out of 10, no, it actually makes it worse. So yes, there's going to be some interaction because we're all unique in our receptors and genetics and so forth, but it's, for the most part, unless they're doing ridiculous studies with super overdosed levels that are not, or injecting it directly into the organs that isn't the way we normally take it, that's the only time I've seen any major adverse effects. Most of them have been supporting overall well-being and improving health. Maybe not curing anything, but making the body more prepared. One of the things I like about CBD and the endocannabinoid system is I've been a gut guy, digestive health and adrenal health and cortisol response, and it's all connected. We've been talking about it with probiotics for years. CBD actually works to reduce inflammation, support the immune system, hits all the receptors in the gut, starts to work with the stress response, and that helps with blood sugar. So it's not a fix this, it's a how can we support the body's own healing capabilities and let the body start to respond and be able to respond effectively. You have a question? Yeah.
Paralyzed months ago from 0.70 or 0.80, 0.80, something like that.
Because a lot of the spinal cord injuries, you're dealing with pain, but also spasticity, and a lot of the data, shows that a lot of times the combination of the THC and CBD for the particular patient population tends to be more beneficial than just a straight CBD or a straight THC product.
Not straight CBD, it's a combination with CBN, CBC,
Mm-hmm.
THC.
Mm-hmm.
What is it, CBG? Something.
Yeah. So
Full spectrum.
like a lot of patients in this, a lot of it's going to be trial and error. Seeing what works and what doesn't.
See,
And the
like
plant's going to be a better, safer option for the most part.
the little boy I mentioned earlier that had the cancer, when I started working with him, he was on hospice. And he was on a morphine pump, and he was getting 16 milligrams morphine. And within a month, we dropped the 16 milligrams down to 8. But he was getting a 1-to-1 CBD to THC. So it was a full spectrum, full plant CBD with THC, as well as the other phytocannabinoids. But within a month, we cut his dose by 50%.
In the back?
Kids that you've seen without major seizure disorders or cancer, so generalized anxiety, maybe high functioning autism, is there a minimal age that you would recommend treatment for? Or under a certain age you wouldn't?
The youngest patient I've worked with was 18 months old.
I'd say we have the endocannabinoid system there for a reason. Obviously, a lot of it, we talk about endocannabinoids from breast milk. So breastfed children get that benefit of sorts and that booster shot of endocannabinoids from the mom. So that's another component, but it sounds like, very young age has shown to be pretty safe in regards to all these.
With all the natural advantages of CBD, why is it that there are so many restrictions on representations about the advantages of CBD being placed on?
Any attorneys in the room?
That's FTC, FDA, and a whole bunch, even DSHEA, which is the Dietary Supplement Enforcement Act, and there's a lot of rules. I think the biggest thing for me is FDA is not designed to regulate, but it's there to protect the safety of the individual. That's what their mission is to protect the safety of the consumer. And so claims need to be researched and validated 10 times over. So.
Yeah, I'll comment on that real quick. So I've worked in the pharmaceutical industry for a long time before coming into CBD. And as you know, these pharmaceutical companies spend billions just to make another claim about their drug. And one of the drugs I supported had 14 indications, and every indication costed just as much. So the FDA wants to make it a fair play for CBD, that how can we make all these claims without doing the double-blind, placebo-controlled trials?
That's good, yeah. And even some of those research, like we said, on the mouse study with liver, there was a cannabis research study done on human trials in California that comparing vaping and smoking and eating edibles, and their methodology was all wrong. And so even the research has to be sometimes questioned, how they, again, they did edibles, they did comparing, I think, brownies, and they basically put ground up flour into a Betty Crocker mix and baked it. Now, if anyone knows the typical way of using cannabis oils in edibles, that's not the way the products are usually made, and they're usually extracted from an oil base first. So their methodology was wrong, and the research findings then proved wrong. So everything's again, we're still young, we're still learning, this is a young industry, frontline docs, and people in the industry that are working on this to decode it, this mystery of dosing. Again, we have a long way to go, but we're making progress. So. One last question, then we're going to wrap up.
How do you, as more and more doctors are getting involved and participating, how do you identify, like we're in Nebraska, we're in the Midwest, and things are just starting, so is there anything within the doctors' organizations where it's identified that there are doctors or, who can and will treat with some of these types of
Right, so in a lot of states, like in the state of Florida, there is a medical marijuana registry, an Office of Medical Marijuana Use. You can go online, the state of Florida, state of Iowa, state of Nebraska, and they will list the practitioners who have taken the courses and become licensed. And then you can, from there, get some names and try to figure out who maybe has more experience.
Now, in some states, it's the opposite. If you are a licensed physician, then you can recommend cannabis. So there's no training, there's no course, there's no registry. So you need to find out what the rules are in your state and then determine, if there's a registry. If not, whoever's advertising or whoever's talking about it, social media, just ask, because I get a lot of patients that way through social media. I need a doctor in Northeast Central Florida, that does medical cannabis, or a medical cannabis doctor that works with kids. And that's, someone will put the question out there and immediately, Joseph Rosado in Ormond Beach, or Dr. Wiener in Miami, or whoever. So.
And there's more certification programs, more universities bringing in programs every day. There's classes at these events that help people become more knowledgeable. So it's got a lot of just research and finding out. There's a lot of good curricula that's out there now, just giving the doctors some baseline. And from 4 or 5 years ago, we were in Chicago, and the medical community was being told not to attend a free event for doctors to become educated on cannabis. Now, fast forward, it's a legal state, and now they're dying for, they're looking for information everywhere they can. I don't use the phrase dying in any facet there. So we're out of time, unfortunately. I know, like I said, we can do this for another hour or so. I hope this was informative to some degree, gave you some insight again, the mystery of dosing. Docs will be around. We'll be around if you have any questions. There's a lot more panels. Thank you guys for coming today. Thank you guys.